So I just went in 2 weeks.
All right, so let's go ahead and get started by finishing up our herpes viruses. So the last herpes virus that we're going to talk about is Cytomegalovirus. And again, this is one that a lot of people may not necessarily have heard of, but it does have a really big impact in certain populations. So it's estimated that anywhere between 50 and 80% of adults will be infected with cytomegalovirus by the age of 40. The majority of them will not know that. And actually, the numbers that I've seen even more recently were something like 85% of adults in the US will have cytomegalovirus. So why is that important? Well, like some of our other infections we've talked about, this virus is really impactful during pregnancy. So especially if the mother is infected during pregnancy, this is actually the number one viral cause of congenital defects. In fact, up to 15% of stillbirths are caused by cytomegalovirus. So so when we talk about a miscarriage versus a stillbirth is a child of gestational age that should have survived. So this is basically a full-term pregnancy or very close to a full-term pregnancy where the fetus has died. And many of those are infected with cytomegalovirus. This can also be very important in your immune-compromised patients. But in general, an otherwise healthy adult almost certainly will not know that they have the virus, will not really experience any symptoms from the infection, and probably wouldn't be diagnosed unless they were specifically tested, and there are a few situations where you might be specifically tested. One of those situations is during a routine STI panel, they may test you for cytomegalovirus. 90 to 100% of people who are screened during an STI panel are cytomegalovirus positive. So it is most commonly associated with sexual transmission. If you are undergoing fertility treatment, they may also test you for cytomegalovirus. If you are female and cytomegalovirus negative, they're going to be very careful during your pregnancy that you don't acquire the infection. If you're positive, you already have the infection, there's really not much you can do. But if you are cytomegalovirus negative, you don't want to acquire the infection during pregnancy, so they'll be very careful about that. It is the largest of the herpes viruses, and it does even carry a little bit of its own mRNA. So it can, basically what that means is that it can get in there, the genetic material will go to the nucleus, right, so that it can begin being transcribed. But it also has some mRNA, so it can immediately do some of its own translation as well. Okay, so it'll package all of that together. The genome itself is DNA, but it will bring some of its transcripts along so that it can start making proteins right away as well. But it does have a relatively slow overall replication rate, and that can help promote latency. If a virus is really slow to replicate, it can persist in the body for a long time. It doesn't necessarily trigger the immune system. So in most adults, again, it will rarely cause symptoms. It's most often associated with sexual transmission, though it can be found in the majority of fluids and secretions from the body. The highest concentrations are in the semen, which is why it's most commonly associated with sexual transmission. One of the things that it can do within the body to help evade the immune system, and we'll see this with other viral infections as well, is that it can interfere with class 1 and class 2 MHC expression. So remember, class 2 MHC is what we're going to see on our professional antigen-presenting cells, so our macrophages, dendritic cells. Class 1 MHC is found on all nucleated cells. So within the human body, there are very few cells that won't have class 1 MHC. Our red blood cells are an example because they don't have a nucleus. Okay. When a cell has a viral infection, because remember, most viruses also don't infect the immune system. So in order for an infected cell, let's say of the respiratory tract, of the urogenital tract, wherever the infected cell is, in order for it to signal to the immune system that there is an infection, it has to use the class 1 MHC to show what's on the inside. So it shows, hey, I have a viral infection because look at these weird antigens I'm producing that aren't me. And then the immune system recognizes and tells the cell to undergo apoptosis. When viruses interfere with class 1 MHC, what they tend to do is prevent class 1 MHC expression. So they prevent the infected cell from saying they have an infection. And sometimes that is a trigger to the immune system as well. It's, if you have children, dogs, cats, whatever, if it's really noisy, you know there's a problem, right? So if the virus is, if the cell is showing, hey, there's a problem, right? You know there's a problem. But also if it's very quiet, you know there's probably a problem. Your dog has eaten something they shouldn't, your cat is probably messing up your furniture, your kids are drawing on the walls, right? These are all situations that happen in my house on the daily, right? But it's too quiet. So that can sometimes trigger the immune system too. So it's really a delicate balance of interfering with the immune system by not displaying class 1 MHC, but you don't want to necessarily completely shut it down either because that also triggers the immune system. When we talk about cytomegalovirus, I told you, yes, we have a lot of stillbirths and other congenital defects. It doesn't always lead to stillbirth, but it can lead to other congenital defects in infants. And really, it's going to be more important as a cause or an issue in our immune-compromised patients. But children can sometimes technically be considered immune-compromised because they haven't developed a nice, robust immune system yet. And so cytomegalovirus is present in a large percentage of medulloblastomas. And this is one of the most common, or the most common, malignant brain tumor in children. So in a study of these tumors back in 2011, the cytomegalovirus induced inflammation and promoted the production of interleukin-6, an inflammatory cytokine, vascular endothelial growth factor, and prostaglandin E, all of which promoted the growth of cells. Treatment with a drug, an antiviral, and an anti-inflammatory stopped the growth of the cells. So this is another virus that can induce cancer formation or tumor formation. So it's an oncogenic virus. So of the herpes viruses that we discussed in class, you're looking at cytomegalovirus and Epstein-Barr that are oncogenic. The Kaposi sarcoma is also oncogenic, but remember, we didn't really talk much about that. So by interfering with class 1 MHC, it can also interfere with the natural killer cell attack. Natural killer cells are a type of cell that will help kill infected cells, so they inhibit that as well. And they encode an analog to IL-10. IL-10 is a cytokine that sometimes people call anti-inflammatory, but I'm probably going to have like PTSD flashbacks about anti-inflammatory for the rest of my life. I had a member of my PhD committee who was like, cytokines aren't anti-inflammatory, they're just not pro-inflammatory. I'm like, whatever, that's fine. So IL-10 is a cytokine that helps to tamp down the immune response. It's one of the cytokines that can be produced and say, okay, we're done, right? No more immune response is necessary. That's why we call it anti-inflammatory, but not if you're Dr. Dubé, and that's fine. But it prevents a T helper 1 response. So it has a number of different mechanisms to evade the immune system, to tamp down the immune system. So again, the predominant presentation in children and adults is going to be asymptomatic. In immune-compromised patients, you can have disseminated disease that can be severe, including in places like the eyes, lungs, GI tract. Sometimes you can have nervous system complications, issues with the lymphoid system, other major organs, and then in neonates, remember, yes, we made a big deal about stillbirths, but some of the other congenital defects can include deafness and microcephaly. So microcephaly is when the brain doesn't develop fully and the child is born with a small head, microcephaly, small head. We see it a lot with Zika virus, but there was just recently, like within the past couple of weeks, an article, like a popular article, not like a science article, about cytomegalovirus, and this woman whose daughter was born with the infection, and she was born with microcephaly and other really significant neurological defects, and she ended up dying as like a teenager. And so she's really pushing for states to screen as part of the mandatory screening for cytomegalovirus, but the majority of the country does not do mandatory screening. So you really wouldn't know until you either had a stillbirth or a child with significant congenital defects. So again, normally you're having an asymptomatic carrier. You can sometimes have symptoms that resemble mononucleosis, but the difference is going to be, remember with Epstein-Barr, we make that heterophile, that weird antibody. You don't make it with CMV. So if a patient turns up with those classic kind of mono symptoms, fatigue, muscle pain, and then you do the blood test and you don't find that heterophile antibody, it might be CMV. When a neonate develops, right, if a woman who is seronegative, she previously did not have the infection, she gets the infection during pregnancy, the neonate will have what they call cytomegalic inclusion disease. They have all those really significant effects. And then if a patient is immune suppressed or has HIV, AIDS, you can have multi-site systemic disease. So it can be diagnosed by histology, cell culture, serology, nucleic acids. That's going to be most common is either serology or nucleic acid-based tests. But remember, the difference in serology, it's going to look a lot like Epstein-Barr. Your difference is going to be that heterophile antibody. Nucleoside analogs, so those kind of broad, if we were talking about them like they're antibiotics, like a broad spectrum antiviral, it should work against lots of different viruses, can be used in immune compromised patients. But again, in an otherwise healthy individual, we are really only concerned about infection in a seronegative pregnant woman. So as long as the person is otherwise healthy, that's cytomegalovirus is going to be something that the majority of people have. Okay. So if you don't, you only worry about infection during pregnancy. Okay, questions?
Is there any treatment, like if we were to catch like a woman who has a test positive?
And the problem is, because they don't do any screening for it, you generally wouldn't know until either you could view fetal abnormalities on an ultrasound, you could tell about the microcephaly, or if the child was born with microcephaly or you had the stillbirth. So it would be one of those that, unless the patient was being tested routinely during pregnancy, you wouldn't know unless there was an effect on the fetus. And again, some of those really broad effects, like microcephaly, can be detected on an ultrasound. But in the US, most pregnancies only do a couple of ultrasounds, one at the very beginning to confirm pregnancy and establish due date, and then a second like anatomy scan at about 20 weeks. So if they don't catch it then, and you can't predict things like developmental or cognitive disabilities or deafness, so it could just be the surprise. So the major issue would be, especially if the mother was infected during early pregnancy, a lot of neuronal development is actually already done by end of second, third trimester. So it's not as big a concern, but especially in early pregnancy would be major.
Can they only find out through the ultrasound, or can they find out through another way?
You probably could do something like, you probably could do amniocentesis, but they generally will leave the fetus alone unless they really suspect a problem. So amniocentesis is not something that they like to do very frequently because it does have a risk of things like miscarriage. But that would be the only way to diagnose the infection in the fetus. You could test the mother. So if you had tested the mother prior to pregnancy and then during pregnancy and she was negative, now positive, you would do something like that, yeah. Any other questions?
But even if she does change from negative to positive, there's really not much they can do about it.
Nothing they can do about it. No. I mean, if you, maybe, maybe you could give her nucleoside analogs and hope that that helps, but you also wouldn't know the effects on the fetus until, in some states, until it would be too late to do anything about it. Yeah, and then if you have twins, they'll do ultrasounds all the time, and so then you get paranoid because you're like, why are you looking at me all the time? But at least you're like, well, at least they would probably catch something, right? Okay. All right, let's get into groups and answer some questions about herpes. So you can either email me your group's answers, just make sure everybody's name's on it, or you can just write it down on a piece of paper and turn it in before you leave. So let's spend 5 minutes till 12:20 going over these questions. So a 2-year-old child with a fever for 2 days has not been eating and has been crying often. On examination, the physician notes that the mucous membranes of the mouth are covered with numerous shallow, pale ulcerations. A few red papules and blisters are also observed around the border of the lips. The symptoms worsen over the next 5 days and then slowly resolve with complete healing after 2 weeks. So your questions are, the physician suspects this is herpes simplex virus infection. How would you confirm the diagnosis? How could you confirm whether or not it was herpes simplex 1 or herpes simplex 2? Herpes simplex virus escapes the complete immune resolution by causing latent and recurrent infections. What is the site of latency in this child, and what might promote future recurrences? So take 5 minutes to answer these questions in your groups. I'm gonna sit in the stanky
Here's
chair.
what I found.
Yeah, that's right. I got presence of viral.
Right? Because like virus for sure, it's like carrier, like cell culture is not that good. You don't know how to handle it.
The only thing that's tricky is HSV1 or HSV2. Number 2 causes brain.
I could write it.
Do you
Have to write down the question.
No.
Okay, so what did we say for number 1? Nucleic acid.
Yeah. The diagnosis, it could be confirmed with direct analysis of the sample, and you can look for inclusion bodies in the cells.
So do a lot of viruses have inclusion bodies?
I think only like 1 or 2 we talked about, like the recent one we talked about, and then this one.
I mean, I don't want to write down direct analysis of symptoms because they don't do that. Parasite analogs.
But aren't nucleoside analogs used to prevent and shorten outbreak?
Yeah. That's right now.
I mean, presence of the antigen.
Okay, what about 2? How can you determine how can you tell between the 2?
Number 2 causes brain.
What was that?
Isn't it because number 1 is transmitted orally more, and number 2 is sexually more? I mean, like they can each cause each other, but orally is more common in like kids and that transmission. Because like how she said, everybody wants to kiss the little kid.
So it's true.
But
So maybe side of infection.
Okay, take just another minute or so to finalize your answers, and then we'll go over them.
What was the site of latency in this child? The mucous membranes of the mouth.
Yeah. And then what makes it
Are in
Spicy.
stress? Yeah.
So stress,
food,
fever.
All right. So the physician suspects that this child has a herpes simplex virus infection. How would they confirm the diagnosis?
or sores and fever blister.
How do you confirm that it's caused by herpes simplex? That it's not just like some other lesion on the mouth.
Like a direct sample from the lesion and then we do testing.
What kind of testing?
Like
The nucleic acid.
Nucleic acid testing.
Serology.
You could do serology.
antigen.
Yep, look for the viral antigens. Yep. You could also look for the CPE under the microscope. If you took a tissue scraping, you could look for like syncytia formation or inclusion bodies in the nucleus. Okay.
Can they detect it with a blood test?
You can, but you could do, yeah, that would be the viral antigens, or you could look for antibody response, or you could do nucleic acid test. Since they have a DNA-based genome, PCR is pretty easy. All right, how could you determine whether it was caused by herpes simplex virus 1 or 2? How do you differentiate between the two very closely related viruses?
HSV1 comes generally orally, whereas herpes simplex virus 2 is generally transmitted sexually.
Generally, yes.
So this is a 2-year-old, so obviously it won't be HSV2. So we also
Well, you would hope, but in abuse situations and things like that, you could see. So that I know it's horrible to think about, but those of you going into the medical profession, you could see pediatric patients who have sexually transmitted infections. I know we don't want to think about it that way, but we could. But you're absolutely correct in that the majority of the time, if a patient has lesions around the mouth, we're thinking herpes simplex 1. If they're genital lesions, we're thinking herpes simplex 2.
Can you also differentiate serologically?
Serologically, they're going to be pretty similar, but there are some differences. So you could do some specific serology, or you could do sequencing of the DNA. Yeah. So I know it's awful to think about, and I'm sorry to like bring you down on a Wednesday, but it is something that you cannot discount the presence of sexually transmitted infections in children.
I have a question, Professor.
Yes,
So when you say for child abuse, they can get SV too?
they could.
If the user has the virus.
Yeah, children that turn up with sexually transmitted infections, it's abuse. Yeah, yeah. I mean, that's why you'll sometimes have situations where like a 10-year-old is pregnant, like, right? It shouldn't happen, but it can. So as a medical professional, it's not where you want to go with your mind, but it is somewhere you might have to go. And we always hope no. We always hope it's just because grandma was giving baby kisses and that's fine. But yeah. And again, for the most part, yes, the majority of oral herpes simplex infections are herpes simplex 1 and genital or herpes simplex 2, usually. It would be very uncommon, but it is not impossible. But sequencing or maybe very specific serology could help you differentiate. Finally, what is going to be the site of latency in this child? First, we'll do that. What is the site of latency in the child? Where is the virus hanging out now for the rest of the child's life? In what type of cell? In neurons feeding the oral area. Yep. And what might promote future recurrences? Stress. Certain foods. Other illnesses. Overexposure to the sun. Yeah, lots of different things. So, but mainly stress, other illnesses, spicy foods, allergies. Those are all real common triggers. Immune suppression, right? Those are all common triggers.
I have a quick question.
Sure.
When you say spicy food, like my son eat that in chips, like a Cheetos,
Uh-huh.
and he got all here like a small really dot.
Mm.
And he was burning since almost 2 days now.
It could be, I mean, it could just be a reaction to like the compounds that are in there. Maybe he had a little cut already that got kind of irritated. So unless you've seen blisters like that before, I wouldn't assume that it was it was herpes simplex. What you would this is what you're probably going to see in the child when they first have the infection. So when they first turn up with the infection, they're going to have lots of lesions as their body is like, having the reaction. But then, later, so if you've seen lots of lesions, maybe, and then it could be irritated by spicy foods. But it could just be, how old is your son? Like,
3.5.
yeah, probably just had a cut or something, got irritated. And my kids are always like, I'm like, dude, you're 2, stop eating hot Cheetos. But they're like, yes, hot Cheetos. So I get it. They like spicy food.
Because, he doesn't want it.
Yeah, no, it weirds me out. I'm like, why do you like hot Cheetos so much? But they do. I'm like, I don't think that's healthy. Please stop eating my chips. Any other questions about herpes viruses? Okay. So we are going to move on then to, I want to say it's pox virus. Yep, pox viruses. I was like, not parvo. We're going to talk about pox. A pox on your house. Okay. So, pox viruses. Those of you who have the textbook and have been going over the textbook as well, you'll notice that there is a section on like monkeypox, but it's kind of out of date. So I added in some more information about monkeypox, which is now called Mpox. So your book will call it monkeypox, but we call it Mpox now. And the recent pandemic around that, because, one pandemic wasn't enough, so let's add a second one in. Pox viruses, so remember, this is, where non-science background people will sometimes think that chickenpox is a pox. It's not. So remember, chickenpox is herpes. Pox viruses are a completely different group of viruses. So pox viruses are some of the largest viruses that cause infection in animals. There are larger viruses, but that cause infection in animals. Pox viruses are some of the biggest. They have kind of an oval or brick-like shape under electron microscopy. They have an envelope. They have double-stranded DNA. And they have a relatively large genome, almost a couple 100,000 base pairs, which is pretty big for a virus. Now, these are a little bit unique from some of the other DNA viruses we've talked about, because the viral particle, when it is being packaged in the host cell, it is packaged with some of its own enzymes, including DNA polymerase. So pox viruses are one of our exceptions to the rule that DNA viruses have to go to the nucleus. Pox viruses don't, because they carry their own enzymes to do replication and transcription outside of the nucleus. They replicate in the host cytoplasm. So via microscopy, if you're looking for the CPE, you're looking for inclusion bodies, you're not going to see them in the nucleus like you would see with things like herpes or papillomaviruses. You're going to see them only in the cytoplasm, because the virus does not have to go into the nucleus. So again, what we're looking at is, because they have their own enzymes, they do their entire, what's unique among DNA viruses here? They don't go into the nucleus. I already spoiled the question for you. They don't go into the nucleus. So that's unique among DNA viruses, because as they are being packaged, right, they package the enzymes they need with them. And again, I'm not going to ask you to remember all of the steps of all of the viral replication, because they're all a little bit different. There are a lot of steps. The major steps: binding, get in, replicate, make your proteins, right? Package, get out. Like that's, pretty consistent. But this is a big one, that they don't go into the nucleus. So because it does affect the CPE that you'll see. You won't see inclusion bodies in the nucleus. Now, the major pox virus, and actually the first, I don't know how many times I taught this class, I only talked about this pox virus, was smallpox. And sometimes I'm like, well, why do I even talk about it? Because smallpox doesn't exist anymore. In terms of, like, there are no humans who have had a smallpox infection in over 40 years. There are 2 places on the planet where smallpox virus technically should exist, only 2 places. One is at the CDC, and one is at an organization called Vector, which is a Russian, like kind of the Russian equivalent of the CDC. But one, geopolitical issues, things like the Cold War. So we could blame the Russians if it's somewhere else. We could also blame us. They found a vial of smallpox at the NIH not that long ago, so wasn't supposed to be there. People get sloppy. Those are the two places it's supposed to be. In terms of natural infection, it doesn't exist anymore. It has a relatively large genome, again, 200,000 base pairs, and a lot of it, 30%, is dedicated to genes that produce proteins to help it evade the immune system. Things like evading interferon, evading complement, evading antibodies, evading the cell-mediated immune response. It's really good at immune evasion. So what we see is that the virus is generally transmitted through inhalation. It can also be transmitted by contact with scabs. So it produces lesions that will scab over, and if you touch them, you can get the infection, but it's more common in inhalation. It will replicate in the upper respiratory tract, get into the lymphatic system, causes primary viremia, and then it can lead to things like hemorrhage of the small vessels of the dermis. That leads to the rash and the pox, but it can also affect other organs. So in terms of why we don't have smallpox anymore in people, why was it relatively easy for us to get rid of? One, it only infects humans. There are no animals other than humans that get smallpox. They all can get their own kind of pox, but they don't get smallpox. Smallpox is a human-specific virus. It is not transmitted by any sort of like mosquito or tick. It is human to human. It didn't really mutate, so there was only one serotype. So once you had smallpox and you mounted an immune response, you were never going to get smallpox again. Unlike the flu or COVID or other viruses, right? Or other types of infection. This is kind of a one and done. Once you've had it, you're done. Okay. It had a very consistent disease presentation. That allowed for people to be like, ooh, that person has smallpox. Let's quarantine them, right? Or isolate them. Yes?
Quick question. What's the difference between the chicken pox and smallpox?
Well, one's a herpes virus, chickenpox. Smallpox is a pox virus, so different family.
Mm-hmm.
So pox viruses are their own family, but we'll see what how the symptoms look very different. So you could really easily be like, oh yeah, that person has smallpox. Very classic disease presentation. So you could quarantine them or isolate them and then vaccinate everybody who could have potentially been exposed. Immunization with animal pox viruses protected against smallpox. So the vaccine, the classic vaccine that we use to vaccinate against smallpox is actually a cowpox virus. It provides enough cross-reactivity that being vaccinated with the cowpox virus protects against smallpox infection. It's a stable, inexpensive, and easy to administer vaccine. And in patients who had been vaccinated, they developed a scar at the site of vaccination that indicated that it was successful. So generally what they did for a smallpox vaccination is they used a bifurcated needle. And I know it sounds easy to administer vaccine, but it would be like 20 stabs in the upper arm in a kind of a circle area like that. The patient would develop lesions and would develop a scar. So in the US, people born before the 1970s, born after the 1970s, have not been vaccinated against smallpox. But my parents were born in the 50s, so they were. So my parents both have a small smallpox scar still from their vaccine. I have only met like one other person my age who has been vaccinated against smallpox, and she was born in Lebanon. So other parts of the world were still vaccinating into the 80s, but now nobody really gets vaccinated against smallpox except for like military personnel or people who work with the virus itself. The World Health Organization came up with a really excellent strategy combining vaccination and quarantine. They called it like a ring vaccination strategy. So if a cluster or even an individual with smallpox popped up, they would quarantine and then they would basically vaccinate everybody who had potentially been in contact. And so they kind of surrounded that person with protection to prevent the virus from getting out.
So is the vaccination for this the kind of like the one that people go around saying that it's like how to tell if you weren't born in the U.S. or you're a foreigner? Because it's like they have like a scar, like little circle scar, like pokes.
Yeah, but even like now younger people are not going to have it either. Like I said, I've only met one person my age, and I'm 40. So yeah, and she was born in Lebanon and has the vaccine scar. But the majority of
Like
yeah.
when did they stop doing it?
Mid to late 80s, I believe, is when they stopped. They might have in some places gone to the 90s, but smallpox was considered eradicated. The last person who got a natural smallpox infection was in 1977 or 78. So once they were sure it was gone, they stopped vaccinating, except for military personnel.
In the previous slide, you said that it can be transmitted through like scabs.
Mhm.
So would you have to have like a break in the skin, or just as long as you touch it?
Well, you could inhale the scab material too.
Okay.
Yeah. I know it sounds gross, but that's how they used to they used to protect against it. So why do we worry about smallpox? Like we don't worry about chickenpox, right? Like sure, we vaccinate against chickenpox, but it's not like that big of a deal, and nobody's coming around knocking on your door like, "Hey, get vaccinated against chickenpox." But they did for smallpox. Smallpox, the virus is called the variola virus. So there were two like kind of types of infection, variola major, variola minor. Variola major had up to a 40% mortality rate. So you would die. Variola minor was about a 1% mortality rate, which is still higher than like chickenpox. In this image, this patient is covered in lesions, right? This is not what you see with chickenpox. And this is not actually that bad of a case of smallpox. The lesions, they could have so many that they would basically just all merge together and the person's entire body is just like a giant blister. Okay. And again, it killed people. So the vaccination campaign, like the worldwide vaccination campaign, began in 1967. By this point, the disease was already eradicated in what were called industrialized nations. Developing nations still had smallpox. So worldwide, it was targeting all of the regions of the world that had smallpox. The last naturally acquired infection was in 1977 in Somalia. And I should have included it, and I'm sorry I didn't, but there's actually a picture of the guy who has it. And he's like standing up against a pole, and I'm sure he's like, I wish people would stop taking my freaking picture just because I have smallpox. Right, so he was the last person that had smallpox as a naturally acquired infection. There was a laboratory exposure in 1978 or 1979. I can't remember which year, but there was a scientist who was not approved to work with smallpox, was working with smallpox in a hospital setting, and it traveled through the ventilation system and killed one of the employees of the hospital. And then the doctor who had been working with it that wasn't supposed to, he felt so guilty that he actually died by suicide while under investigation. The disease was declared eradicated worldwide in 1980. So they waited a few years after the last naturally acquired infection to declare it eradicated. The previous vaccine strategy was not actually vaccination, it was called variolation. And I told you, you can get the disease by inhaling the scabs. And so what they used to do, and this goes back even like over 1,000 years to, it was first documented in China, and they have like drawings of it. They would take scabs from a patient who had smallpox, and they would dry them out because it's an envelope virus, it's sensitive to drying, to hopefully weaken the virus. And then they would take that powdered material and blow it up the nose of a patient who had not had smallpox before, because they knew if you got smallpox once and you survived, you're fine. So they tried to give the patient weakened virus so they would hopefully develop a weakened form of disease. and then be protected from a more significant form of disease later. And it actually worked really well. And so when people from Europe were traveling in Asia and saw that this was their strategy, they brought it back to Europe, and it was done, like that was the vogue thing to do, right? Have the smallpox things blown up your nose to protect you from infection. And again, it worked really well. Sometimes people died, right? I feel like in Shrek, some of you may die, but that's a risk I'm willing to take. But it worked. As long as it was dried out enough to weaken the virus, but not so much that all the virus was killed. But once Edward Jenner used cowpox to protect against smallpox, that's why it's called vaccination, because cowpox is vaccinia, vaca, cow. So vaccination is because of cowpox. They outlawed variolation, and they provided the vaccine for free in places like England. And by free, I mean they made you do it. Forced you to do it. Okay, so this is from 2007. A woman visited a public health clinic in Alaska because pain from vaginal tears had increased over the course of 10 days. No fever, itching, or painful urination. Clinical examination showed 2 shallow ulcers, redness, and vaginal discharge. No swelling in the groin area lymph nodes. Often when you're looking at ulcers in the vaginal area, that's syphilis. That's kind of one of the common symptoms, and that's why a lot of women don't know that they have syphilis, because they have ulcers on the inside, they don't see them. So men will usually notice the ulcer on the outside. But this woman had ulcers on the inside, right, in the vagina, and when the scrapings from the lesion were actually examined, it turned out she had cowpox virus. Presence of the virus was identified by a type of PCR, although the woman routinely insisted on using condoms during sex, always a good practice. A condom broke during intercourse with a new male sex partner. The male partner was in the U.S. military and had been vaccinated for smallpox 3 days before initiating the relationship with the woman. So virus from the lesion was either placed on the condom or into the site. So most likely, like, he touched the lesion and then either touched the woman or touched the condom when putting it on, and that got the virus in the vagina. Military and other personnel receive immunization for protection against weaponized smallpox. So we don't know who has smallpox. We don't know what they've done with it. So the idea is, if a country has weaponized smallpox, at least the military is protected. This increases the potential for unintentional transmission of the vaccinia vaccine virus. Other cases of vaccine-related vaccinia infection have included infants and individuals with atopic dermatitis. It's a type of autoimmune skin condition, who had more severe consequences. So it's rare for somebody to turn up with cowpox, but if they've had contact with somebody in the military who's been recently vaccinated, it is possible to get somebody who has cowpox lesions.
So recent vaccination can cause you to be susceptible
to cowpox. Yeah, because they use a live cowpox. It's not like a killed cowpox. And so if the person has the lesion from the vaccination, yeah. So that's why it's got to be recent vaccination. If it's, been a month and the lesion is healed, you're not going to see it. It's going to be somebody who's recently vaccinated. So that's why it's pretty rare, but
So by lesion, do you mean the site of where they injected the
Mm-hmm.
vaccine?
Yeah, you'll so we don't really see this with our vaccinations, because we typically, if you're not military, don't get vaccinated against something like that, but it will cause like a blister at the site. So it's not just the redness we classically see with the vaccine, but it'll be like a blister indicating that it's taken and causing the infection. Yeah. Okay. So our next pox virus is called Mpox. It used to be called Monkeypox, but that's not a terribly accurate name, because monkeys are not the main host or the reservoir. It's actually more commonly found in rodents. There are similar symptoms to smallpox, but it tends to be a much more mild infection. So you would have lesions, but it's not going to be like anything like you see with smallpox. Very, very few lesions compared to smallpox. You will have swollen glands, and that can differentiate from other conditions that cause a full body rash. I mean, sometimes you might be in a clinic and a patient comes in with a full body rash and you're like, okay, well, let's go through my list of things that could cause a full body rash. Okay. Mpox is one of them. There was a previous outbreak in the US, which is why it's included in the textbook, in 2003, and it was associated with pet prairie dogs. I did not know that you could have a pet prairie dog, but apparently you can. And these pet prairie dogs had somehow come into contact with Gambian giant rats, which sounds like something I have no intention of ever being near. There were 71 cases of what we now call Mpox in the US in 2003. So again, the lesions look a lot like a smallpox lesion, but even with that smallpox patient I showed you, they had like pretty dense blisters all over their body, and here it's not nearly as significant. Now, the reason that I included Mpox in here, and I normally would skip it even though it was in the book, because like how many people have a pet prairie dog? Like that's super weird, was because there was an outbreak that started in 2022. I did not have that on my bingo card. So 2020 we got COVID, 2021 was the giant like murder hornets, and then 2022 was Mpox. Nothing happened this year. It was first detected in May of 2022 in the UK in a patient who had recently traveled to Nigeria. So he developed symptoms of a rash in late April, and in early May flew back to the UK where he was diagnosed. Since then, it has been confirmed in 111 countries and suspected in 2 more, but not confirmed. It is less transmissible than smallpox, which is aerosolized and can be transmitted through the respiratory. It requires close contact, like physical contact. Without treatment, there has been anywhere from 1% to 3% mortality in this outbreak. Remember, with smallpox, we were looking at sometimes upwards of 40% mortality. With treatment, it's even lower, so some antiviral therapies can help. As of October 11th, those were the most recent statistics I could find. That's pretty good. Worldwide, just over 90,000 cases with 161 deaths. About 31,000 cases confirmed in the US. So we in this country have one of the biggest burdens of cases. We have about 1/3 of the cases and 54 deaths. So 1/3 of the cases, about 1/3 of the deaths. Worldwide, we're looking at, these are the countries that have had the infection. The countries in blue are countries where the virus is normally endemic, where it would not be weird to see Mpox. The countries with orange are the weird ones. We don't expect it. And of course, the bigger the circle, the more cases. So, lucky us. Now, there are vaccines that are available for people at risk for transmitting Mpox or for acquiring Mpox infection. They are actually smallpox vaccines. Remember, I told you there's a lot of cross-reactivity. They are vaccinia virus. They're cowpox-based vaccines that should protect against smallpox, but also protect against Mpox. And I'll show you on the next slide, but most countries maintain a stockpile of smallpox vaccines, just in case. So these vaccines were already in existence. They were already stockpiled by a number of different countries, by the World Health Organization. So it was relatively straightforward to begin giving them to at-risk populations. There's also post-exposure prophylaxis. So because it has its own enzymes, there are some antiviral therapies that can be taken relatively soon after exposure to help prevent symptom development. So within 4 days, you can prevent the development of symptoms at all. Between 4 and 14 days post-exposure, you can at least reduce the severity. And so there's, of course, the attempt to reach at-risk populations. And what we tended to see with this Mpox outbreak was that the most at-risk populations were men who have sex with men. I don't know why. It just kind of established itself in that community. And so I know that those individuals were the first ones offered the vaccine. And again, I told you that we have stockpiles. So the US maintains a stockpile of 185 million doses of smallpox vaccine. So in theory, if smallpox came out, as a bioweapon, we could, with pretty rapid response, vaccinate about half of the country. Other half? Okay. So again, there are some drugs that work. There's a general Poxvirus treatment because it inhibits the Poxvirus DNA polymerase. And other antivirals can work as well. Okay. So those are our Poxviruses. If